really looking forward to doing this talk with you guys. I always enjoy speaking at this conference. And I really, it's been time to kind of talk about this. We've had the Obesity Clinical Practice Guideline that when this first came out last January, we had a lot of opportunities to talk about what was in it, what was said, and people have gotten a chance now to really react to it, try to implement it. And I think we've really have a lot of lessons learned. This talk, when I talk about it now, it's really evolved over the year and a half that this has been out. And there's a lot of fun stuff going on with it. So I also would like to save a little bit of time at the end for everybody, because I hopefully you'll have some questions and hopefully we'll have some answers for you as well. As Mark said, I'm a retired pediatrician from Northern Kentucky. I am first and foremost a generalist. Even though I'm very involved with pediatric obesity and have done some advocacy work in some other areas, I really am a general pediatrician. So I really try to bring that voice to it. As Mark said, I'm a former chair of the AAP section on obesity, remain very active there. And then also too, in the role in obesity, it's all over the place. I'm really interested in everything from infant feeding practices and really even the prenatal environment, all the way through adolescence. So I think obesity work is a great place for us general pediatricians. I'm also a bit of a geek when it comes to community research and about behavior change. I have nothing to disclose. So our learning objectives are pretty basic here. We want to describe and reinforce for you how we should be thinking about weight issues and thinking about obesity as a chronic disease. We're going to review the key action statements, and then we're going to go a little deeper. We're going to discuss some of the current challenges to implementing this huge document. And then I try to identify some strategies for you that you can take home. So let's first off go over, what does the Obesity CPG really say? And what did it say when it came out 18 months ago? Well, if you remember, the CPG is something very different. It's not, I think people said, oh, it's an update. It's this, it's that, it's the renewal of this or that policy. It's really not. This is the first time we had enough data to actually do a clinical practice guideline. If you recall from what the AAP had released prior to this were clinical reports, policy statements, expert guidance. And in fact, the thing that everybody was kind of working from was the expert guidance thing that came out in 2007. This was the first time we really had enough data to actually put together a clinical practice guideline. And that's why there was a little bit of a delay in it coming out. It took a while. It took 15 years, in fact. We went through 16,000 abstracts, 1,600 full text articles, 382 articles made the cut. From that, we came up with 2 technical reports, 11 consensus recommendations, and 13 key action statements. Just a reminder, a key action statement is based on evidence and varying levels of strength of evidence. The consensus recommendations are kind of like the expert recommendations were before. And you'll see, I'll talk about this a little bit. You'll see why some of these have to be consensus recommendations. They just don't work as key action statements, either because the evidence isn't there or because it's not something you can really easily test for. I'll show you what I mean by that too. If you recall, this document is really about pediatric obesity. And when this first came out, I was getting interviewed by a lot of different places. We were getting interviewed by NPR, and remember I was on a national broadcast from WBUR called On Point, and I was getting grilled about, well, shouldn't we be preventing obesity? And I'm like, the answer to that is, of course, yes, we should. But to recall, this document really addresses 2 areas: assessment and treatment. So evaluation and treatment. And so we're going to kind of talk about those 2 areas in different pieces, in different parts. There is an area of advocacy, which is very important, and I don't want to give that short shrift, but it really is about the evaluation and treatment of pediatric obesity in a clinical setting. So let's talk about assessment and evaluation. What are the challenges with this? And there are challenges with this document from start to finish. So, you get things like people saying like, well, with evaluation, BMI isn't perfect. Well, yeah, it's not perfect. But there are strategies for dealing with that. The BMI is a vital sign, that BMI is something that is where we are, but it's not the be all end all. There have actually been some good indications. There was a great meta-analysis that came out just last week and a half ago that really talked about how BMI is a pretty decent predictor in the majority of kids for adiposity. Obesity affects everyone differently. It certainly does. No one will say that obesity for one person is the same. It's kind of like any other chronic disease. It will affect people at different severity and in different ways. So in a number of ways, qualitatively and quantitatively. So many things go into causing obesity, it's impossible to look at everything. Well, those of us in the obesity world, we tend to have a certain personality type. We tend to be people who like chaos, and obesity is chaos. There are so many factors. There are so many things that go into causing it, and it can cause so many things on the output side. So it really is complicated. Doesn't mean we don't need to address it. It just means we need to be systematic about how we address it. So who cares about weight? It's health that matters. And you hear this a lot from certain corners of the world. It is about health that matters. And that's why we care about it. Obesity does cause health problems. As much as we'd like to say it doesn't, it does. And there are good reasons why we need to treat it. Shouldn't we just treat the comorbidities? Well, we certainly do need to treat the comorbidities, but if we have an underlying trigger for those comorbidities, it makes sense to treat that underlying comorbidity, and the guideline really addresses that. There are just way too many things to evaluate for. Well, we're physicians, we're pediatricians, we've never been intimidated by that before. Well, maybe we've been intimidated, but it hasn't stopped us from trying to address things just because they're complicated. So let's dive right in. Remember the first key action statement here, that we should measure height and weight, calculate BMI, assess BMI percentiles using age and specific CDC growth charts for kids between the ages of 2 and 18. Again, it's not perfect, but BMI is a vital sign. It's something that we need to use and put in context for our patients. Meaning, like if you have a heart rate that is 40, is that heart block, or do you have a highly conditioned athlete in front of you? So it's something that we need to use as a vital sign. Again, not perfect, but that's what we're caregivers for. We have to interpret this and help our patients interpret it. A consensus recommendation, and here's the first one, you'll see why you can't do a study on this. The consensus recommendation from the group is to say that we should perform initial and longitudinal assessment of individual structural and contextual risk factors like racism, that to provide individualized and tailored treatment for child and adolescent with overweight or obesity. And again, you're not going to double blind this and not assess this in certain patients. So that's why this is a consensus recommendation and not a key action statement. We can't give you a pile of resources or a level of evidence to tell you completely on this one, but it's good practice. And we know from a lot of other inferential data that it's important to do these things. We should evaluate for comorbid conditions. Pediatricians should evaluate for obesity-related comorbidities by using a comprehensive patient history, mental and behavioral health screening, social determinants of health, physical examination, and diagnostic studies, because all of these things have evidence to show that they have an impact on obesity and the outcome of treatment of obesity. So what does this lab evaluation look like? And again, those of you who've seen this before, we're going to go over this fairly quickly because I'd like to get to the implementation issues on this. So if you recall, key action statements 3 and 3.1, and I'm going to go over these with key action statement 5 a little bit together with this. I want you to think about this in maybe a little different way. So what these two are saying, if you look at key action statements 3 and 3.1, this is addressing children who are 10 years and older. So key action statement 3, in children who are 10 years and older who have obesity, we should evaluate for lipid abnormalities, abnormal glucose metabolism, and abnormal liver function in those patients over age 10 with obesity. And for patients that are in the overweight range, have overweight, we should be checking for lipid abnormalities. For kids 10 and older who we may want to evaluate for abnormal glucose metabolism and liver function in the presence of risk factors. And in the younger children, 2 to 9 with obesity, we also may evaluate. So it can get a little confusing, but think about it in this way. Over 10, have obesity, you screen for everything. If you're not over 10 or don't have obesity, you're sort of in the may evaluate for things based on your risk factors. The other thing I would say in here too, I just completely lost my train of thought on this one, so we'll come back to it. Let's talk a little bit about what we do with kids under age 10 who have obesity. We want to make sure, and I remember what I was going to tell you. If you think about this, if we go back just for a second here, if we go back to our kids who are 10 and older, if you're following the American Heart Association guidelines to do a screening on all patients between 9 and 11 for lipid profile in your office, you cover this. So a lot of pediatricians are saying, well, I already do this on all my patients, and that's absolutely adequate for doing that. And that's what we always did. So this was sort of off the table, the lipid evaluation, because we just did it on everybody routinely based on those AHA guidelines. All right, now that I got that out of the way, sorry about that. So we talk about dyslipidemia further. We should probably do a fasting lipid panel on anybody 10 and older who has obesity and may evaluate for patients between the ages of 2 and 9 with obesity. So if they have overweight over age 10 and they have obesity between the ages of 2 and 9, we may also want to evaluate for dyslipidemia. So it's a little confusing. I always ask you just to take a look at it if you're confused, if you have a patient in there, but generally, if they're over 10 and have obesity, you want to screen for everything. If one of those two factors, age and they're in the overweight range, then you have to do a little bit more thinking on which is going to be more appropriate. And it usually goes down to whether or not they then have risk factors. Prediabetes and diabetes should be evaluated. What does that mean? How do we do it? It means we should use a fasting plasma glucose, a 2-hour plasma glucose after a 75-gram oral glucose tolerance test, or my personal favorite, a glycosylated hemoglobin. And we generally use a level of 5.7 as a cutoff there. There's some interesting data coming out, and there's a big U01 grant currently looking at evaluating kids as low of hemoglobin A1Cs as low as 5.3 for progression to prediabetes and diabetes type 2. But there'll be more on that coming out. But currently, you can use any of these 3 tests. So MASLD, or metabolic dysfunction-associated steatotic liver disease, the old NAFLD. We should definitely be evaluating for this by using an ALT. I generally get an ALT working in an obesity clinic, as I did for several years. We would always get an ALT, an AST, and we'd also get a gamma GT. The AST and the gamma GT can help you parse out some other things, but really the most data is that the ALT is really the most sensitive test. And if you recall, for a lot of patients, we always used to use 40 as a cutoff, and a lot of labs will say the cutoff for liver disease is 40, when really it's probably as low as 24 for kids. So that we'll see a little bit of controversy on this, but ALT is definitely the way to look at this. We should evaluate for hypertension by using basically the recommendations that come from the AAP hypertension screening guidelines. Consensus recommendations for other comorbid conditions. There's not as much data to make key action statements around these, but they include some very important illnesses that we need to be aware of. Things like obstructive sleep apnea, polycystic ovarian syndrome, depression, Blount's disease, slip capital femoral epiphysis, and increased intracranial hypertension. So, certainly pseudotumor cerebri is not very common, but a very serious and life-threatening complication that we need to be on the lookout for. And the take-home message from all of this screening, a couple of things. We need to be looking for disease because it often exists in our patients who have obesity. And we need to treat these comorbidities concurrently with their obesity. Treating obesity treats these conditions. That's why we care about obesity. It's the health concerns, and addressing the root cause, we think, has a good basis in evidence. So that was truly a 30,000-foot view of the key action statements for evaluation. So let's move on what do we do with this information. So the treatment challenges, there are a lot. Weight bias is everywhere. It certainly is. And even if our role is to fight back against that, I can only do evaluation in my practice. And what good is that? Well, I think it can be a lot of good. When we say, we do screening, I do a lot of work in preventive medicine stuff with the Ohio chapter of the AAP. And we have this question all the time, like if I do screens, but I don't have any place to refer them, how is that helpful? Well, if we don't know we have a problem to begin with, we're never going to be able to fix it. When we sent out the clinical practice guidelines, I think every last one of us knew you can't sit on the data. That's not ethical. If we know that treatment works, the fact that treatment isn't out there yet doesn't mean that we shouldn't be saying that we need to address it. Everyone needs something different. They certainly do. It's a very individualized treatment. There aren't enough treatments out there. Truer words have never been spoken. It's incumbent upon us to try to change that. Payment stinks. It certainly does. And we need to be working on that. I'm scared of prescribing medications, and another valid complaint. We'll address that a little bit. And they don't get reimbursed anyway, including mostly about medications. We're making some progress, and we'll talk a bit about that as well. Surgery seems extreme. We always get that, and there are some workarounds to that challenge as well. So I think it's useful to think about obesity structurally. Like, how are you going to think about this as a provider? One way to think about it, some people really like algorithms. We have an algorithm for you in the clinical practice guideline where you can really sort of drill down and go through those evaluations like we talked about. Like, I really do think that those recommendations on treatment around lipids can get really confusing. And I'm sure I may confuse some people more than before the talk. But I think an algorithm can kind of help you sort that through a bit. And some of us think very clearly through that. And the algorithm even goes into a little bit more about treatment and where people go with that. So I encourage you, when you look at the AAP website on this, if you're an algorithm person, it's pretty well laid out in there. The other way to think about this is your medical home. We think about this in the medical home and sort of a gradation of treatment, where at the bottom level here, we talk about ongoing assessment of individual social contextual risk factors. We evaluate for comorbidities and find what kind of treatment we have for these. As our number of resources go up, we're able to provide more. It may be that we learn a little bit of MI and do some shared decision-making around for parents on what they're going to do. It may be that we have things that we can refer to that provide some intensive health, behavior, and lifestyle treatment. And certainly our role may be getting to the point where we sometimes maybe even provide pharmacotherapy, or we refer for pharmacotherapy, and we refer for surgery. And it all should be done in the context of the medical home. So I think these are just two ways of sort of thinking about it conceptually, what our roles are as pediatricians, to think about it as an algorithmic sort of way or in a medical home sort of way with increasing levels of complexity. There are some basics, though, with comprehensive obesity treatment. When we start looking at treatment, we should treat overweight in the medical home using a chronic care model that is family-centered and is non-stigmatizing and that we do not practice in weight bias. If I had more time, I'll put in a little plug for the Kentucky chapter of the AAP. We're doing a half-day session on how to implement some of these things in very practical ways in your office. And we address, making your office look less, eliminating weight bias in your office, basically. And we can kind of go over those things. But it's important to really create an environment. And even if you do that alone, that says a lot to your patients with obesity. We really need to be able to be thinking about what we can do. We want to do the most intensive that we can do and the longest that we can do, provided in the medical home. I come from a practice that I absolutely love my practice, just wonderful people, great patient population, just an awesome idyllic sort of setting. And I remember when I was going through with my partners about obesity, and I was kind of taking this approach. I was saying, like, hey, if you have somebody with obesity and you don't want to deal with it, you send them over to me and we can work with them. And Amber, who's our nurse practitioner, and Rachel, who's one of our PAs, can take it from you from there, and we can do this all for you in the office. And all my partners really kind of gave me a good, like, no, that's not what I want to do. I mean, I have the relationship with this family, and yeah, I may not know all the tricks of the trade that you do, but my association and my connection with this family to promote things is more powerful than knowing those tricks of the trade. And I could not agree more. I think my providers, I sort of shorted them a bit. Most of them said, like, no, I know this is hard. I know I'm not an expert in it, but this relationship that I have with them and the fact that I've been seeing them for this many years, sometimes it takes a lot less for me to say that because I have the relationship. And I can't stress that enough. There are some patients who just need a quick discussion. And while those patients are few and far between, maybe they really aren't that few and far between, that sometimes those basic things really make all the difference. I can give you examples of that throughout my practice where I said, like, why don't you do 5210? And then the next year, they come in a different body type. So, we forget that sometimes there are some patients that just need a little bit of knowledge and a little bit of nudging. So it's really important to stay in that medical home as much as we can and do this from a longitudinal basis. One of the key action statements that really warmed my heart when we sent this out and the data was coming back is that motivational interviewing, while it's not the be-all, end-all, there is a lot of good data that motivational interviewing makes a difference. And I would say obesity is the tip of the iceberg where motivational interviewing can help you in practice. So it was good to get some data behind it, saying that, we've all been saying, am I, is there any data behind it? Yeah, there is data behind it. Does it work by itself? No, not many things do. But motivational interviewing can kind of help reset the discussion that you have with families. It can really help you with weight bias. And I think it really helps you in dealing with behavior change across the board. You don't learn motivational interviewing if you just wait to do it with your patients with obesity. You need to sort of adopt it as a strategy in your office. But what I will tell you is that it helps with weight issues, and I really think it helps with a lot of frustrating discussions you might have in your office. There are ways to build capacity for MI. We've always had the Change Talk app. That's like a virtual simulation one. There are recorded didactic sessions that you can find on the AAP website. I would also say that if you have the interest in doing a longer course, I happened to take one that was offered at the University of Minnesota School of Public Health. It was one summer course. I just sort of dove in and did it. Tremendous, tremendous experience. The message of all this is, you want to deliver treatment as much as you have capacity for, as soon as you can and as extensively as you can. So what does that mean for doing the really intensive stuff, the intensive health and behavior lifestyle treatment? I always think it's kind of unusual that it's IHBLT, like I heart BLTs. That's not really the acronym, but it's one way to remember it. But intensive health and behavior lifestyle treatment, we should provide or refer for 6 and older, and may provide for age 2 to 5 who have overweight and obesity the option for intensive health, behavior, and lifestyle treatment. Wow, that's a lot of kids. That's a lot of kids. So everybody over age 2 who's in the overweight or obese range gets offered intensive health and behavior lifestyle treatment. That's a lot. And that doesn't necessarily mean that that's what's going to happen. And we all know that that isn't what's going to happen just because of capacity issues. But what it does mean is that we should start thinking about it, and that it is useful to talk about nutrition. It's useful to talk about growth trajectory. It's useful to bring it up as a discussion. The more often we do it, the earlier we do it, I really think the more we normalize it and the less we stigmatize it. If we're really going for full-scale IHBLT, if you notice, we say it includes 26 hours or more of face-to-face, family-based, multi-component treatment over a 3 to 12-month period. Again, very robust. What does that look like if we do that in practice? And how can you even begin to do this? Well, in the state of Kentucky, we do not have enough of these programs, like many at all, honestly. So when we do IHBLT, what does it look like? And it can look like a lot of different things. It can be it's patient, family, and a multidisciplinary team. It should happen on diagnosis. It should happen. There should be some health education, some skill building, some behavior mod, but it can be in group, individual, or both. We can do it in the healthcare setting. We can do it in community settings. It should be longitudinal, and like I said, the more intensive, the better. It should be face-to-face or virtual. And so there's some flexibility here, but it's as much and as often as you can deliver it. You can learn more about IHBLTs by going to the AAP website, and we'll have all these links for you. But there's a lot of information out there about different programs that exist. Some of these ones that are recognized also by the CDC are quite good. Programs like MEND, the Mind, Exercise, Nutrition, Do It one, which is down at the bottom. It's a British program. Smart Moves, Bright Bodies, Building Healthy Families are another good one. There's another one that's coming out of North Carolina that came out of Bull City Fit that you'll see around as well. There's a lot of different programs out there.
She's going to her parents' house around the corner.
If you go look on your website, on the website, you'll see a lot of these things. When you're looking at IHBLTs and trying to evaluate them, you want to look for ones that fit the definition that I gave you of 26 hours and multi-component. You want to look for things that do address stigma, that are developmentally appropriate, that are consistent with the chronic care model, and that value a level of partnership with the medical home if they're not particularly based in your office. When it's not available, which is a lot of the time, you build collaborations and do the best that you can do. We have ways for you to assess your capacity for building this out in primary care, how you can intensify your care, what the key content should be. There's some support tools and some key principles for you to remember if you decide to build this out in your office, which more and more practices are choosing to do. I love this schematic because I think it really gives us permission to go where we can go with this. Maybe you're over here at the left side where you're making obesity treatment a practice priority. And then you start getting better at screening for things. And then you get better at ordering labs. And then you get better at screening for social determinants of health and comorbidities and eating disorders and mental health issues. And then maybe you start doing a little bit of tracking, and then you start identifying your subspecialty network and your team training. And then maybe you start identifying regional obesity treatment centers and metabolic and bariatric surgery programs. And then maybe you build your own IHBLT. You don't have to start at the right side of the ramp. Nobody can. You start off slowly, and in each of these sub areas, you start off slowly and work your way up. There's nothing wrong with going slowly in this area. This is a tool that I think is really helpful that, and if you come to the Kentucky chapter thing that's going to be out at Tom Sawyer State Park, we're going to have you fill this out. Basically, we have you look at your capacity for doing this. This is on the AAP website. It's aap.org/obesity CPG. It helps you really look at like, okay, what do we have? You know, when I really think about it, when I take a deeper dive mentally, what do we have that we can build upon? And there are also QI programs, which I think QI programs are a great way to really assess your capacity and build things out. There are strategies of using community programs to help your clinical approach. There are multiple formats, some that work for better for other places than others. Some people have access to more disciplines than others. Some of you will have a dietitian already in place. For some of you, that is nowhere to be found. So you need different ways and different strategies for intensifying care as you're able to do it. Some other strategies that sometimes help, I always had this vision in practice that I was going to have weight management afternoon. Well, as like what if your weight management afternoon is the day of your patient's soccer practice? Like, I don't want to take them away from their soccer practice. That's more important than sitting in the office and talking with me for most of my patients. So I think that there is a possibility for some people to block for treatment visits, not necessarily on a day, but you have them blocked throughout at different points through the week, usually at the end of the day or the end of your sessions. So if they run long, you have a little bit more time. You want to build systems and processes into your schedule that you have time for follow-up visits. Some people have had success with piloting group visits. Never been one of my favorites, but some people really have good success with it. You can utilize your patient portal. There are different strategies for success on this one. I also think it's so important in Kentucky that we look at our community linkages. We have some amazing community partners out there. Being around the state, I just am like, some of these places they just rock it. They have a great YMCA. They have a great parks and recreation system. Some places do not have those things. It's one of those things where you have to look at your glass half full kind of stuff. Don't complain about what you don't have, but look and see what you do have. I remember Mike Kudaku, is the president of KMA, and when we were looking at Winchester, they had a really good parks and rec system. Now, at that point, they also wound up losing their YMCA, which was a big loss. But you really want to look at some of your community partners. And some places, there are things that you wouldn't even expect, food pantries or farmers markets that are able to take SNAP benefits, places that are wanting to do a culinary program. So be really creative, look in your communities and see what you've got. There are going to be some things that will surprise you and some things that you really wish, like, oh, we need to work on getting this. You want to ask some really key questions. I'm not going to go through these one by one, but you really want to talk about with your community partners some operational questions. When you're building a multidisciplinary approach, remember you want the things that are important. As Mark said, I recently retired, and we know that the importance in that is nutrition, exercise, sleep, and social connectivity. It's the same way with obesity. It's around nutrition, physical activity, and social connections, and it's also about sleep. So you want to really look at your multidisciplinary approach. Are we hitting the three areas here? And also, too, are we working on sleep? Because it's an important piece, and that's a topic for another day. Evidence-based strategies can look at a lot of different things, but we know that they can often, they can encompass a lot of different behavior strategies. There are definitely tools that can help you support this. I like Next Steps, that's been around for many years, comes out of Maine, that has themed visits. It's a flip chart that you can do themed visits with your families. Really a wonderful program. There's a lot of stuff on My Plate from USDA that also, there's a lot of good materials out there. And I tell you, our chapters, look around at our different chapters for some of the materials that are out there. There's a lot out there these days. The thing about successful IHBLT, it contains all these things. This is just a graphic that's on the website to kind of help you remember, like, am I addressing this? Am I addressing that? There's also a lot of patient engagement and retention resources. There's podcasts. There's, as I mentioned, there's QI programs. There's also a lot of good handouts that you can use with your family to families that are already populated now on the AAP website to help you out. It's a very helpful website. Okay, pharmacotherapy. So exciting and really an interesting area to look at. So we should be offering adolescents 12 and older pharmacotherapy as an adjunct to behavior and lifestyle treatment. Okay, so what does that mean? Does that mean that we should all run out and start prescribing medications for everybody 12 and older? No, it does not mean that. Some of us are not comfortable doing that. Some of our families do not want to do that. Some of our patients have needle phobia. Some of our patients are just not at a point where they're going to be able to do any intensive health behavior lifestyle treatment. They are not candidates for pharmacotherapy. It means that pharmacotherapy should be in your thought process and maybe your discussion with the family. It does not mean, as some people thought when it first came out, we all need to start them on Ozempic. That is not what we're saying. We should offer between the ages of the younger kids the possibility of it, and start thinking about it. What does this really mean? If a patient has obesity, we need to let them know that there is therapy out there, but there's a lot of pieces to this therapy that we need to make sure of before we get you started. And it's always to be used in conjunction with IHBLT. When we're diving into this, I always say to people, you start off slow, then you work your way up to the 1 meter board. And we're not starting off at the Olympic 10-meter platform right out of the gate where you have to know every medication that's out there. Maybe you start off with one medication when you're ready to start the medications. When you're getting started, maybe you start with GLP-1 and one of them, or maybe you start with topiramate. For the general pediatrician, if you think about it, this is how we got started with ADHD and SSRIs. We weren't good at it. And maybe we just started with Zoloft at first, or maybe we just started with Ritalin at first. And then we became a little bit more savvy as we moved along. Use your pharmaceutical reps wisely. They are there to sell you a product. However, they also can be very helpful in teaching you how to use these medications and some tricks of the trade. It's going to take a while for us to learn the billing process. It's getting better, I will tell you, but there are still challenges. I'm always amazed. I had a patient about 4 years ago that was on our biggest insurer in the state of Kentucky, but was eligible for it based on the fact that the parent was a public employee. Motivational interviewing more than ever. Again, this is a joint decision. This is not something that you just prescribe and see you later. And the mantra continues, not to be used without ongoing IHBLT. It is a must. This is not a start medication, turn off everything else, and just eat like you've been eating. If you're looking for more on using meds, I have a few things to recommend to you. The University of Minnesota has historically done a great job, Advanced Therapies for Pediatric Obesity Conference. I have no connections with this conference, but it is a very well-attended and excellent conference that really gets you up to speed on it. There's an excellent course that the Obesity Medicine Association does. Also, what used to be known as the Blackburn course, that's in the Boston course in obesity medicine. All great courses. I would also say, and looking on the Norton website, there is listed a pharmacotherapy for use in obesity treatment on the Norton website. So, don't limit yourself to pediatric conferences. You're not going to find as many, except for the advanced therapies one in Minnesota. Most of these are going to be in adult settings, and that's okay. You'll still learn the physiology, you'll still learn the other stuff, and then you can learn the nuances of the pediatric piece as you get closer to doing it on your own. But learn about the medications and really take advantage of those opportunities that show up locally for you. Metabolic and bariatric surgery. We should offer referral for 13 and older for patients with severe obesity for evaluation. Could I get any more qualifiers in there? We're not saying you have severe obesity, you therefore need to have metabolic and bariatric surgery. No, we need to talk about it, and we need to talk about what those options are. We also need to know our referral patterns. Who's working with kids? Who's not working with kids? How far do they have to go? Is it even practical for this family to do it? Are they motivated to participate and follow up as they're going to need to across from one of our 120 counties? A few things to remember about this. Making aware, again, does not mean you're sending them for surgery. It's statements like, you know what, we're in a zone where this is a possibility. I would potentially think about going to X, Y, or Z center to get this evaluated. There's more data for surgery than there is for pharmacotherapy. I think it's hard to remember. Parents a lot of times are going like, well, I'd rather do pharmacotherapy first because we can do it here. And that's true, but there's really more data around bariatric surgery. Sometimes centers of excellence are the gold standard for adults, but because of the number of patients, you're not going to find centers of excellence for patients that have pediatric patients. Close follow-up is important. Pediatric comorbidities are different in prevalence and severity from adult ones. So these are things that pediatric facilities provide that some of the adult ones, even centers of excellence, do not. And they also need to have access to all the allied pediatric services. Also with kids, I would say behavioral health is front and center. I mean, you got to know, these kids have to be able to understand what's going on to the best of their ability. So what are the key takeaways here? Obesity is a chronic disease. We need to treat the whole child and do an evaluation for the whole child. Obesity treatment is safe and effective. There are effective evidence-based treatments and strategies for treatment. Treating obesity also means treating comorbidities, and that's why we care about treating obesity. And children with overweight or obesity should be offered treatment upon diagnosis. Doesn't mean they have to take you up on that, but you should be offering it. And you should be offering it in a way that is non-stigmatizing and non-judgmental. So that is a ton of information. And Mark and Emily and Karen have asked me to save some time for questions, which I gladly do. I think questions are always a great way to kind of hit those areas that I didn't hit in enough detail. And that was a very rapid presentation on stuff.
No, that was great. A reminder to our symposium participants, please enter your questions in the Q&A section or the chat in Zoom. So some questions. How many patients in your practice did you have on GLP-1 agonists?
We had so I did retire about 18 months ago.
Oh.
And so when I was in practice, I had 3 patients that I was giving in my practice. Now that's a little unusual because I'm sort of known as an obesity doc. My practice actually quit doing it after I left. I thought I had them all set up for it, and they were not comfortable doing it. I said, guys, if you're not comfortable, don't do it. And I would say currently they have about 8 to 9 patients that get their medication through an obesity center at Cincinnati Children's.
And then what is the success rate of those drugs?
So, when we were writing this CPG, all these things are being reviewed, and those of us on the writing group, it's a writing group of about 15 people. We did not know what we had a feeling, because we know the literature, we had a feeling what was going to come back from our reviewers, but it came back a pretty strong recommendation that, we have a lot to learn, but it was, patients lose they're pretty close to what they lose, maybe a little less than what they lose with bariatric surgery. So, with certain patients who are on GLP-1s, their GLP-1s are definitely the most effective. But our patients who are on GLP-1s were losing and keeping off, as long as they stayed on the medication, were keeping off about 20% of their body weight.
Wow.
Whereas, so it was pretty impressive.
And did you have patients that had gone as far as bariatric surgery?
Yeah, the issue with bariatric surgery, and we know a lot about bariatric surgery. There were these three big studies. There was Teen Labs, that was a follow-up and corollary of the lab study that was done in adults, a multi-center trial. And there was FABS 5 plus, and AMOS. AMOS mostly was done in Europe. And these studies, really have a lot of good data, of good longitudinal data. Those patients lost on average about a third of their body weight. So there were definitely some pieces that we really needed to get out. And we'd kind of this, I think that one probably wasn't as controversial as the pharmacotherapy one, because people had been kind of used to the statement that we had issued on bariatric surgery. But the take-home message on that one is bariatric surgery works. You can count on losing about a third of your body weight. You'll have with a little bit of regain. But over time, the majority of patients keep the weight off, although we all know the stories of those patients who gained it all back. The patients who got bariatric surgery, they wound up having a lot of resolution on comorbidities. I always think it's fascinating, like, the thing where if you have type 2 diabetes that we think is weight related, patients, their type 2 diabetes resolves almost before they lose any weight after bariatric surgery. What's that about? Clearly, we don't understand everything metabolically that's going on there. But it works. It works it reduces the weight, but it also does something metabolically that changes the comorbidity profile. So we know that it's helpful. The issue with it is we want to talk about it early, because if you remember, I'm saying like you lose about a third of your body weight. So we want to get those patients when they're 300 pounds and they get back to 200, as opposed to 400 pounds and they get back to 300 or 290.
Okay. So what about fasting insulin as a marker for insulin resistance? We usually see this before A1C changes to prediabetes. Okay,
I'm a believer. Okay, so I like it, and I do it. And Nancy Crimmins, who is an endocrinologist at Cincinnati Children's, also a Kentucky resident, but she's a believer in it too. And I think it's useful as a yes/no sort of question. So like if I see a patient and their fasting insulin is elevated, I think that's very helpful to know. What it is not helpful, in my opinion, and I'm going to couch this with my opinion, what I think is not helpful, it's not helpful to use as a track. You can't use it to say like, oh, your fasting insulin was this, now your fasting insulin is that, you're therefore improving. It's a yes, no. Do you have insulin resistance? Do you not have insulin resistance? And so you can't use it to track. And I also would say that there's not enough evidence. If you notice, we didn't say anything about that in the guideline, because the evidence is just not there to say that it is useful. And you will have a lot of endocrinologists. Nancy gets a lot of grief at the Endocrine Society because there are a lot of endocrinologists who say, do not check it. It is not helpful. It is confusing. It is really variable. We know for sure, like I say, it is not a tracking item. It is used on you're going to find endocrinologists from both sides of the divide.
Okay. Is Medicaid or insurance covering IHBLT?
Yes and no. We're getting better. And what we're finding is we're fighting for it. So I've been in Frankfurt a couple of times. We keep going back. We have some people in the Republican supermajority who we have their ear. We're trying to get it there. There are some programs that get covered on a basis. I find that when you have a center like, at Children's in Cincinnati, or the high BMI clinic that Aurelia Radulescu runs at UK, they get covered by Medicaid. It is tough, but it's getting better. And it's also, we used to have to always, Mark, deal in this zone where we had to use the comorbidities, and we still use comorbidities. They're very important, but we don't have to play this game of like, oh, if you say obesity, then they quit covering it. So it's getting better. We have a long way to go.
Okay. And how long would a patient stay on pharmacotherapy? Would they, until they get a healthy weight, or is this forever?
So this is something that this is a discussion that you really have to have with families on this topic. This is a chronic disease. You start insulin for diabetes, you're going to be on insulin because you're not producing you're producing insulin. So we tell the families, if you're going on this, you have to think about this as a lifetime sort of commitment, which is a lot for patients to go. And they're like, oh my gosh, I don't know if I can do that. I don't know if I want to do that. And do we have, 50 years of saying this is what happens with kids on it? And we all know there's side effects with everything.
Yeah.
So, it's like they have to have their heads wrapped around that. Once they come off, there's a good chance of regaining. Now, do people go off of it? Does it prevent them from saying, like, I'm going to take this until I get to a weight that I'm happy with, my comorbidities are resolved? Really, the comorbidities resolving is the issue. And then I'm going to try it off of it? Sure, there's no problem with doing that. It's just that I think people need to go into it knowing that they're dealing with a chronic disease. And you may not come off your Enbrel if you have JIA, but you may. You may. We change, and management changes. Our bodies change. So you can't make grand pronouncements. Same thing for everybody.
Okay. All right, we're out of time. Dr. Bowling.